Good morning. I'm David Cohen from St. Francis Hospital and the Cardiovascular Research Foundation, and welcome to TAVR Future Perspectives. My co-moderator is Professor Eberhard Grube from Germany, and we have a terrific panel including Philippe, Garot, Kentaro, Hayashida, Cheol Lee, Jung-Hin Lee, Michael Lee, too many Lees, Tullio Palmerini, Carl Poon, Shinichi Shirai, Chung-Sun Hu, and Nicholas von Meegen. So without further ado, let us get started with the first talk, which is given by Professor Alan Young from Stanford on the upstream management of aortic stenosis.
Thank you, David. Good morning. I'm going to apologize for doing this very quickly, because given that I only have 8 minutes. So my topic is the upstream management of aortic stenosis, my disclosure. I think this particular this title is really quite confusing to me, meaning what does it really mean in terms of upstream management? And I kind of use coronary artery disease as a model, which obviously we have spent the last few decades trying to understand the pathophysiology, the risk factor modification, and detection of coronary disease, whether it is by calcium score, by CCTA, stress tests, and angiography. And also we have established from this conference, as you have been the last few days, the criteria for treatment, whether it's symptoms, anatomy, and now with physiology. And the options of treatment, which is whether it's medical, PCI, and CABG, also very well defined in terms of the effectiveness and durability of treatment options. So if you use coronary artery disease as a model, we really don't know much about the upstream management of aortic stenosis. For example, pathophysiology and risk factors. As we know that the incidence of aortic stenosis increase with age, but these are relatively old data in the sense that by 75 and above, not everyone have aortic stenosis, really talking about a range of 5 to 10%. The difficulty obviously is that as you get older, many patients actually succumb to other diseases. Therefore, the incidence of true aortic stenosis in the patient population above 80 years old obviously is difficult to ascertain. And there's many sort of a proposal of pathophysiology. Many of them sort of revolve around the similar system as coronary artery disease, meaning leaflet infiltrations, injury, macrophage sort of attraction into the subendothelial space, create microcalcification. And then ventricle also obviously react in a certain way, leading to fibrosis and subsequent ventricular dysfunction. These are felt to be factors, but I think, again, this is sometimes related to age, so it's somewhat difficult to really sort of parse it out. Early on, we thought that treatment of these patients with statin may decrease the progression of aortic stenosis, and these are some of the early studies. But as we know now that from more data as well as randomization clinical studies, there's really no clear evidence that treatment of aortic stenosis, especially in a somewhat sort of medium stage, doesn't really create anything as shown in these few randomized studies, whether it is in terms of looking at the jet velocity, the gradient. So I think there's pretty much now fell out of favor that you can actually modify aortic stenosis progression by using statin therapy. So what else is there? Again, I think that's really the puzzle, is that there is really no known proven medical therapy to slow or prevent the progression of aortic stenosis. So we always, when we don't know what's going on, we'll try to do GWAS study, which is genetic sort of a study of pick all the different genes in your body and see what is associated with valvular calcification, aortic stenosis. So this is the Manhattan plot, which basically shows that probably one thing that sticks out there is the level of Lp(a), and basically related to aortic valve calcification. So that's something to watch for. Obviously, the problem is that we don't really have good treatment for elevation of Lp(a) yet. I think the incidence is kind of interesting. It's about 20% of the general population. Therefore, if you translate to age, potentially that could be sort of a big factor why certain people above 80 get aortic stenosis. So again, treatment will be oncoming once we have some more data in terms of these treatment that can actually lower Lp(a), that particularly for coronary disease prevention. So we know that it's probably multifactorial, but again, same time, many of these are related to aging. It's a little difficult to decipher. So what is some of the prospective clinical studies? Obviously, PCSK9 that potentially can lower Lp(a) as it stands now, that I think that could be a potential treatment. And obviously some of the newer molecules in terms of ability to lower Lp(a) directly may be of interest once we have that approved as a drug for treatment of Lp(a) itself. So I think that's the difficulty, is that there is really incomplete understanding of pathogenesis. And when you don't understand pathogenesis, how can you treat it upstream in the very beginning? So the questions I always ask myself is, why are there certainly a lot of octogenarians have pristine aortic valves? So why is that the case? And the risk factor modification we talked about typically are very late in the natural history of aortic stenosis, therefore probably doesn't matter at that point. And I think should we really study aortic stenosis progression or prevention? I think that's very different. And are all tricuspid valves equal, meaning that are there some of them subtlety in terms of the three leaflets that are not equal in size or in terms of its arc of support that may lead to aortic stenosis? Again, obviously the left ventricle is subject to many other diseases, for example, coronary disease, myocarditis type of situation that can varies the subsequent response. So I think detection, we can jump through this very quickly. There's some studies using EKG, potentially adding nowadays machine learning to see whether you can pick some of the early signals of aortic stenosis. Obviously, adding echocardiography to it will help the sensitivity and specificity. Though, detection-wise, is there really a calcium score equivalent for early aortic stenosis? Again, we don't have much data. We have data of people who have a severe aortic stenosis. We know the high calcium score is associated with that. But how about early on? Again, very little clinical study at this point because we don't screen these people with a CT scan, for example. So what is our criteria for treatment? As it currently stands, obviously, is aortic stenosis by symptoms and also by gradient, typically 40 millimeters or above. And we obviously know symptoms as it stands by the original Ross and Bromwell slide. There's a sort of a sudden spot that symptoms start to disappear. But clearly from our clinical follow-up of many of these patients, the symptoms can be sometimes very difficult to discern. Sometimes very obvious, sometimes it's like very subtle in their presentation, especially in the elderly population. So I think there was really a fundamental fallacy is that there is this sort of slow progression when there's no symptoms. I think that's really what we're trying to address in studies, that are symptoms an important part of the treatment strategy. And again, I think the third component that, as General has pointed out, that we can look at the ventricular response. Again, I think that's the third piece of the decision tree, is the symptoms and the gradient and also how the ventricle is responding. And again, I'll jump through this very quickly, is that the ventricular response that is bad obviously leads to bad mortality after AVR. And I think it's clear that in moderate AS, that similar pattern can be followed as well. So mortality is up in these patient population. So what is really going forward in the future is really addressing two issues, and actually three. The question is that if they are asymptomatic, should we do the valve if the valve is quite severely diseased? The surgical data, whether it's a recovery trial or the Avatar surgical study, shows that indeed you should probably treat the disease, and the symptoms may be a minor component because many of these patients benefit from a surgical approach. In the TAVR world, obviously early TAVR will be presented later this year in TCT, and therefore we'll hopefully get some results of whether symptoms is an important component. And moderate AS, meaning if patient's gradient is less than 40, 35, 30, does it mean that we should wait or we should actually treat? And I think the PROGRESS study, which has complete enrollment, will hopefully provide us with some data as well. So to summarize, obviously, we typically use symptoms, you use gradient, and nowadays maybe adding some ventricular function evaluation. So clearly, if you have symptoms and the gradient, you would, and ventricle as compromised, you would treat. If you are moderate AS in terms of the gradient, you might, obviously, we are asking that question in PROGRESS. If they have no symptoms, we will be addressed in early TAVR. And I think the early stages really is the big puzzle, is that we don't understand the pathophysiology, so how do we treat that? So I think that will be a lot of study going forward to understand many of these patients' progression and in the future. Thank you.
Thank you very much, Alan. Very nice review. And next up will be Dr. Yohei Ono. from Japan, who will be speaking about valve thrombosis and degeneration.
Thank you for your kind introduction. Ladies and gentlemen, I would like to quickly overview valve thrombosis and valve degeneration. So we know that there's two entities in this topic, and we need to distinguish two entities. One is clinical valve thrombosis, which is mostly symptomatic, and it's associated with clinical impact, like stroke, myocardial infarction, and valve failure. While the subclinical valve thrombosis is usually asymptomatic, and it still doesn't have a very strong relation with the clinical impact. Why is it important? Because, as you know, there's a type of bioprosthetic valve dysfunction, and this thrombosis plays an important role in the setting. So, as written here, clinical significant thrombosis, it means that clinical sequelae, thrombotic event, or worsening of ASAR. So it impacts the valve function. I would like to introduce a very nice case that we experienced 7 years before for bicuspid aortic valve. It was like type 1 bicuspid, small calcified raphe, perimeter was 72.4. The superannular measurement was around 67 to 70.5. So it was actually recorded as part of the videotaped case in our domestic congress. So this was the final angio for this patient. Evolute R, 26 millimeters at that time. So the post-procedural echo showed minimum PVL with low gradient, single digit, good effective orifice area. This was the post-procedure CT scan. A little bit of thickening of the leaflet, but no obvious thrombosis. Annual follow-up was performed up to 3 years, low gradient, no symptoms. 4 years follow-up, slightly elevated mean pressure gradient, slightly elevated D-dimer with BNP elevation, but the patient was really asymptomatic, so we just kept on follow-up. 5 years, there was a significant mean pressure gradient to up to 27. Starting right after the procedure, it was 6.2, so more than 20 millimeters mercury elevation was significant. So as per definition was severe SVD. So I'll show you the CT scan later, but it showed significant valve thrombosis. Patient was kind of symptomatic. So we started anticoagulation for him. It responded very well. It went back to single digit, 5.1 millimeters mercury, and large effective orifice area. So this was a serial CT scan. This was immediately after TAVI. As I showed you, a slightly thickened leaflet and slightly very low amount of maybe thrombus. 5 years later, was really significant, combined with a valve hemodynamics deterioration. And the right panel was the 6 month after the anticoagulation therapy. It responded quite well with the improvement of the hemodynamics. So which modality to detect? I think the baseline follow-up annually after the procedure. Obviously, this transthoracic echo is the type of modality to choose. But in case of any suspicion of elevated gradient or any symptomatic of heart failure, any thrombotic event, I guess we should confirm with the CT scan and in some cases with transesophageal echo as shown here. So the biggest interest is whether subclinical leaflet thrombosis impacts the valve durability in the long run. There's no still robust, strong data at this moment, but some studies suggest there's a relationship between, possible link between bicuspid valve thrombosis and potential calcification in the long run. So I think we need to detect early this phenomenon and potentially intervene as quickly as possible if it's significant. So we have actually pathology lab in our institution, and we do a lot of things, including the coronaries and all those stuffs. And we are getting to the valve pathology thanks to our colleagues in Japan, we collect failed valves, both transcatheter and both surgical valves. And we find a lot of interesting things, like this is the core valve, like 2-3 years after non-cardiac death. The right one is the tear matriclip. This is the failed surgical valve. So in this specific case, there was a valve failure with sapien XT 7 years after the procedure. Severe SVD with severe symptomatic aortic stenosis was explanted, was sent to our lab. All 3 leaflets shown in the left below hand showed severe calcification shown in the X-ray. And pathological assessment showed like a calcified nodule that we can often see in the coronary. So I think the initiation of this process potentially could be thrombosis. And if you leave it, it could be organized thrombi, and then eventually could develop to a calcification. So to conclude my talk, valve thrombosis could happen along the follow-up. The screen with transthoracic echo, we can confirm with CT scan or transesophageal echo. Clinical valve thrombosis should be intervened, mainly with anticoagulation. And whether this subclinical valve thrombosis translates to valve durability needs further clinical investigation and follow-up. Thank you for your attention.
Thank you very much, Jung-Hee. Very interesting. And we move to the next one, David Cohen. And he has to, in 8 minutes, talk about challenges with valve and valve TAVR, role of bioprosthetic valve fracture, coronary protection, and leaflet modification. Good luck, David.
I think my time is up after that. Thank you very much. It's great to be back here. These are my relevant disclosures. So, valve and valve TAVR, as both for surgical valve and now TAV and TAV, is increasing. Currently in the United States, it's about 5% of all TAVRs are placed in a surgical valve. And with both approaches, there are 2 major challenges that we're all aware of. One is patient prosthesis mismatch because of stacking the valves inside of one another, especially when we're treating small surgical valves. And the second, which may be even more severe, is coronary obstruction. And so I'm going to talk about 3 points, 3 really tips around valve and valve TAVR, talk about positioning the second valve, bioprosthetic valve fracture, and some techniques for preventing coronary occlusion. So there are some very nice benchtop simulations and benchtop studies looking at the position of, on the left here, core valve devices, on the right, balloon expandable sapien devices, and how the impact of positioning of those valves within the valve plane affects the gradients in the valve area. And the consistent finding is that the higher you can place the valve, the more aortic you can place the valve, the lower the gradient you're going to get. And so in general, that's what our algorithms are designed to do, and this is what we should try to do, unless there are other countervailing reasons, like high risk of coronary obstruction if we place the valve, the second valve, too high. So that's the simplest thing that we can do, is always place our valves higher rather than lower. Bioprosthetic valve fractures, what happens when that doesn't work well enough? So this is actually one of the very first cases of valve fracture that we did. It was a patient, a fairly large man in his 70s, who had a 19-millimeter Magna valve placed, and about 6-7 years later came back in with bioprosthetic aortic stenosis, and we did a valve and valve TAVR with a 23-millimeter Evolute R. You can see the pre-gradient here was 63 millimeters of mercury, and after placing the valve and post-dilating the core valve, it still, or the Evolute R, it still had a 44 millimeter gradient in the valve area of 1.0, so pretty clear high degree of patient prosthesis mismatch. And this led us actually to develop and pioneer the technique of bioprosthetic valve fracture. This was that case. You can see inflating a true balloon up to 18 atmospheres, and you can see the valve fracture happening right here as the ring of the bioprosthetic valve releases, and the final gradient in that case was 18 millimeters of mercury with a valve area of 1.9. This really spurred a whole field, and I hope that almost everybody here at this point has had the opportunity to do valve fracture cases, because it is a very important technique to know because of the large number of relatively small surgical valves that are out there. In addition to reducing the gradient, there may be other benefits of bioprosthetic valve fracture with regard to valve durability. This is a benchtop study done by Janar Sethananthan showing an undersized, underdilated, in this case, sapien valve placed inside of a previous valve. And when it's undersized, you see this effect we call pinwheeling, where the leaflets are all curled up. And then after valve fracture in this model, much more attractive appearance when the valve is closed. We believe this may lead to greater valve durability, although this is a hypothesis that has not been tested or proven yet. If you're going to be doing bioprosthetic valve fracture, it's very important to know which valves can and cannot be fractured. This information is all in the Valve-in-Valve app, and so that's a very easy way to figure that out. You can see here the main ones that are used in the United States, which are fracturable, including the Magna, Magna East, MitraFlow, Mosaic, the newer generation peri-mounts that look just like the Magna, Magna East, and now the Inspirus valve, which is easy to fracture because it has a built-in weak spot in the ring that will allow the fracture much more easily. Then there's a second group of valves that cannot be fractured, but they can be what we call remodeled. These include the peri-mount and, importantly, the trifecta valve, which there are quite a bit of in the United States because they had the best hemodynamics when they were implanted, but they have now been removed from the market because of early valve failure, and so we see a lot of these coming back. These valves can't be fractured, but the posts of the valve can be bent by high pressure dilation, and we call that remodeling. And then there's a group that you really can't do anything to at all. The Avalis and the Hancock 2 valve are examples in the United States. In terms of going to be doing balloon fracture or balloon remodeling, the positioning is a little bit different that you have to remember, and it's particularly relevant if you're implanting a core valve, an evolute, because you can, if you misposition the valve and oversize the balloon, you can damage the valve leaflets. So with bioprosthetic valve fracture, we're dealing with an issue of a problem in the surgical valve, and the constraint is at the ring of the valve. And so in those cases, you want to keep the balloon that you're using to fracture the valve low. And you can oversize if necessary because it's not extruding into the valve, even with a core valve or evolute. If you're doing remodeling, on the other hand, that's a problem above the valve plane, and you need to balloon higher. And in this case, you have to keep this. You have to really respect the size limits that are given on the valves in order to avoid damaging the valve leaflets. Finally, just a few words about preventing coronary occlusion. This is, I think, something that is getting more and more traction in the United States. I hope it's getting some more traction around the rest of the world because it's going to be very important, not only for valve-in-valve surgical valves, but TAV and TAV. And the idea, here is all of us dread this complication of coronary occlusion at the time of valve-in-valve or even native coronary occlusion. In a recent Spanish TAVI registry, the incidence was about 5% in valve-in-valve TAVR, which was much higher than with native valve TAVR, and the in-hospital mortality was 37%. Importantly, a few of these procedures, these complications can even present late. We need to understand the risk factors because you want to be able to predict this in order to intervene before it happens. The main risk factors are small sinuses, low coronary heights, a short valve to coronary distance of less than 4 millimeters, and then also surgical valves where the leaflets are mounted exterior to the frame, like the MitraFlow and trifecta. Here is an example of a 21 millimeter MitraFlow where we were planning on doing a 23 millimeter S3 with valve fracture. You can see here the distance to the left coronary artery is 2.8 millimeters. The right is even closer, 1.2 millimeters, and so this is a case where we planned and did a double basilica procedure in order to prevent those occlusions. There are two main techniques for preventing coronary occlusion. This is the simpler and perhaps more popular one around the world, which is chimney stenting, where, again, you have pre-wired and placed the stent distal to the left main. At the time of valve implantation, after valve implantation, you can take angiograms and decide whether there is compromise of the ostium, and if needed, then you can do this snorkel stent or chimney stent where you pull the long stent back from the left main and really just prop open the area of the obstruction. If you have to post-dilate, you want to do kissing. And this works once. I think that's the important thing. This is a one-time deal. It'll get you out of trouble, but you're going to have a lot of trouble if you ever have to come back and retreat that coronary artery. It's going to be almost impossible. And so we prefer whenever feasible, to do some form of leaflet modification. This is the basilica procedure that really was developed and pioneered by my colleague Jafar Khan, among others, where you position a snare below the aortic valve, you wire, you burn through the valve leaflet in the area just abutting the coronary ostium, snare that wire, and then after creating what's called the flying V, which is an area of denuded wire that carries the electricity, you electrify that wire and make a slice through that valve leaflet, which then splays open the leaflets and allows blood flow through the valve frame, even in cases where there is very, very close contact between the valve frame and the coronary ostium. This is a challenging technique still because we're doing it with off-the-shelf components that weren't built for it. There are several devices that are coming along. This is the Telltale system, which is a purpose-built wire that has insulation on it. It has an area that is denuded in the middle. It comes with its own kinker, so you don't have to worry about messing it up when you're doing the kinking, and it actually simplifies the procedure quite a bit. We've done about a dozen or so of these procedures with it, and it absolutely makes the procedure much more efficient. And then the other device that I think has a lot of promise is the shortcut device. And the shortcut device is a mechanical device, not electrical. It's a little bit easier to use, I believe. I have never used it myself, but the idea here is you can position this almost like a bioptome-like device, which has a knife that it extrudes, pokes through the leaflet, and then you simply pull this device back gradually, and it makes a slice in that valve leaflet. A first-in-man, an early feasibility study has been completed in the United States, and I hope that we see those results fairly soon. So finally, just to summarize, valve-in-valve TAVR is an important TAVR subset that prevents several unique challenges, the first being patient-prosthesis mismatch, which can be often minimized by thoughtful selection and placement of the TAVR valve. And then if that fails, or if the original valve is very small, bioprosthetic valve fracture is a useful technique for improving the valve hemodynamics. We still need long-term outcome data. Coronary obstruction is a more feared technique. Really, this is all about preparation on the CT scan. And then in addition to coronary protection and chimney stenting, basilica and its variants are promising approaches to preventing coronary obstruction. And then newer devices that are coming along really should hopefully democratize this procedure so that many more people can do it effectively and with a high degree of skill. Thanks very much.
Thank you very much, David. Excellent job. And the next is our friend Jung-Min Ahn talking about the bicuspid TAVR of the Asan Center experience, technical issues, and data from the Asan Medical Center.
Thank you, Dr. Grube. I'd like to discuss with about the bicuspid TAVR. Actually, large of a discussion point for the treatment of bicuspid aortic valve stenosis by TAVR. So clinical and anatomical challenge, we already knew that. So, but the clinical evidence is very limited. This is a whole available evidence published in the last year. So even though the SAPIEN 3 and Eberhard are based on the TVT registry suggests that there is no hard endpoint difference between the tricuspid aortic valve TAVR and bicuspid aortic valve TAVR. So I summarize the whole data, 1,000 to 12,000 patients, to compare the bicuspid and tricuspid. That's still no difference, but the bicuspid aortic valve TAVR increased the PVL and aortic valve aortic root injury. So there is, so how about the TAVR and SAVR in bicuspid aortic valve stenosis? Very limited data. The one study showed that no difference regarding mortality, 3.1, and another study showed that SAVR is numerically increased the risk of mortality in bicuspid AS population. How about the self-expandable and balloon expandable device? Older generation data show that no difference, and current generation data show that no difference. But even though there is a significant difference regarding the complication, as we can expect that SAPIEN is associated with a higher risk of annulus rupture aortic root injury, but the self-expandable device is associated with a higher risk of moderate or significant paravalvular leakage. So what is the bicuspid valve is associated with the patient age. Even in the surgical valve trial, the older age is associated with less incidence of bicuspid aortic valve, but the younger age is a higher incidence of bicuspid AS. So previously, I summarized all data show that even in the Asian, the bicuspid TAVR is very limited. In China, data is very high. This is related with the patient age, I think. So calcium is very important. In the bicuspid aortic valve, one important characteristic of bicuspid is a higher amount of calcification. This is our data show that the bicuspid aortic valve associated with the 600 mean 600 calcification volume, but tricuspid aortic valve is associated with, it shows that the 300 aortic valve calcium, so bicuspid on average twofold higher, larger aortic valve calcification compared with the tricuspid aortic valve. In addition, some valve location and morphology are associated with a higher risk after TAVR. The severe calcification, Leaflet calcification, and LVOT calcification. Dr. Hyun nicely demonstrated that the aortic valve calcification, bicuspid aortic TAVR, if a patient have the calcification with the high risk feature, is associated with the higher risk of mortality. In addition, bicuspid aortic valve is also frequently associated with the ascending aortic dilatation, even though some data suggests that the aortopathy associated with the bicuspid aortic valve is not delayed further after the surgical AVR. Recently, data show that the surgical surgeon suggests that the indication of ascending aorta replacement is not that difference between the tricuspid aortic valve and bicuspid aortic valve. So I like to suggest that the higher surgical risk patient, just TAVR, low surgical patient, if ascending aorta is dilated more than 5, I would like to transfer patient to the surgery, but the less than 5 or 5.5, I like to suggest the TAVR. Device sizing is very important. The DDA nicely demonstrated that based on the BBD registry, they measure that the intercommissural distance and annular size. They define the 3 different categories: tubular type, flare type, tapered type. The most patient bicuspid aortic valve included in the tubular or flare type. So this means that overall 90% patient, the device sizing can be based on the annular sizing. Only 10% we have to consider the supraannular sizing. There are 2 devices, SAPIEN and Evolute. So I didn't use the Evolute too much, so I'd like to focus on the SAPIEN series. So SAPIEN, I think the annular sizing is enough because SAPIEN 3 remodels annulus, but even though the most important thing is don't do oversizing too much. After introduction of SAPIEN 3, the predominantly implanted SAPIEN 3 in patients with bicuspid aortic valve. This is a proportion of bicuspid AS according to the age, younger age, higher incidence, older age, lower incidence, overall around the 13%. This is a type of bicuspid aortic valve. Type 1 is the most frequent. This is the procedure in hospital outcomes of TAVR with the SAPIEN 3. So we perform the more frequently volume valvuloplasty. So conversion to operation is very rare. The ppm is numerically higher. Pericardial centesis is very rare. Coronary obstruction is nothing. Annulus rupture, no annulus rupture. Significant PVL, statistically insignificant but numerically higher in bicuspid population. This is clinical outcome. Matched cohort, there is no difference, numerically lower event rate in the bicuspid aortic valve population because the younger generation, therefore the less comorbidity in bicuspid AS population. So I like to emphasize this graph. So this is the initial SAPIEN 3 oversizing by calcium volume. if calcium volume is very low, arbitrarily we define the low calcium volume is less than 400, intermediate 400 to 1,000, more than 1,000 is very high calcium. Low aortic valve calcium, the similar sizing algorithm to the tricuspid. It doesn't matter a little bit more oversizing. But the severe bicuspid aortic valve also, when associated with the very significant calcification, we have to reduce the volume and significantly undersized. Bicuspid AS, heavy calcification, high risk morphology. I'd like to apply the 0% oversizing, sometimes less than 0%, 95, and then upsizing. This is the procedural complication according to calcium volume. Yes, but there is no significant difference between the tricuspid and bicuspid. So this is an example. So severely calcified, but the undersizing is very effective and very safe. 700, very large annulus, even though 9% undersizing, very minimal parabolic leakage, clinical outcome is very acceptable. So severe calcified AS and bicuspid AS, don't do oversizing in SAPIEN 3 implantation. This is my conclusion. Bicuspid AS has a distinct clinical and phenotypical characteristic, younger age, more severe aortic valve calcification, and associated aortopathy. The incidence of PVL is increased compared with the tricuspid aortic valve cohort undergoing TAVR. Caution should be exercised regarding aortic root injury, so don't apply the oversizing. TAVR for bicuspid AS is not associated with an excess risk of mortality and stroke. SAPIEN 3 implantation on bicuspid aortic valve is not significantly different from SAPIEN 3 implantation on tricuspid aortic valve. However, there is a need to establish criteria for selecting patients with bicuspid AS who can be successfully treated with a TAVR, similar to the echo score used in the rheumatic mitral stenosis. Thank you for your attention.
Thank you very much. We now have about 10 minutes for discussion and questions, and I would ask if the questions are directed to people who aren't on the panel, if you guys come up to answer them.
Can I kick off? Jung-Min, excellent as usual with Asan. And Asan likes to put up rules, calcium scores, certain regulations on how to do things best. So with bicuspid valve aortic stenosis, and I said it the other day, I remember a live case when I did the case and Nicolas was in the panel. We had a relatively fierce discussion, friendly discussion about the sizing issue. We've seen this slide, and you say, 88% of the annulus is correct, and if you do the calcium volume, you have to do it this way or that way. I think with all the advantages that you have by putting up these rules, we still have to individualize. And first of all, I'm not convinced that the annulus measurements is the way to go. Second, I'm not sure whether the volume of calcium alone is predictive of complications. It is not only the volume, I think it is also the calcium distribution that makes it different. And then, if you have a big chunk of calcium relative to others, the calcium volume might be low, but a chunk of calcium might be more difficult. Would you comment on this?
Thank you, Eberhard. This is a very important question. So yeah, this is very, very important as well. The location and the chunk of calcium is very important. But the overall, I believe that the overall amount of calcification can be representative of patient overall risk. But as you mentioned that we have to consider, consider the location and chunk calcification. Particularly, there is a very chunk calcification at the Leaflet. We have to consider the volume, the lower than, even though the overall calcification is overall calcium amount is low, well, the location is very chunk calcification at the Leaflet, we have to reduce the volume, I think.
Okay, thank you.
Didier?
Yeah, maybe just a short question directed to Jung-Hee or Kentaro. It's about the potential higher risk of halt in bicuspid aortic valve patients. Do you have in mind a couple of explanations to this phenomenon? Do you think that it's the underexpansion or some issue at the level of the leaflets? What do you think could explain that potential higher risk of halt and thrombosis in bicuspid patients?
So thank you very much, Didier. Actually, we haven't checked the distribution of the leaflet thrombosis in the patient with bicuspid yet, because the prevalence of bicuspid valve in our country is quite low, 2% or 3%, and we don't have that much data on this. Maybe you may have some opinion.
Well, very important, relevant question, Didier. So I think what we have learned from the CT study from Minneapolis show that underexpanded valve frame, either balloon expandable platform or self-expandable platform, carries a risk of halt and valve, not deterioration, but suboptimal valve hemodynamics. So I think we need to consider maybe potential post-dilatation and try to make the valve as circular as possible, obviously within the safety limits. So, thank you.
So let me follow up on this theme of bicuspid valves and ask the panel for opinions on whether we need a bicuspid valve versus surgery, TAVR versus surgery randomized trial. And I mean, as I think many of you are aware, there is at least one trial which is, I think, going to be starting in Europe sometime this year. There is also a trial in the United States that has been submitted to the government for funding. So we will see. So what are your opinions on the need for a trial in bicuspid aortic stenosis?
So I think there is a fair number of patients that can have both TAVI and the surgery. So I think we definitely need a randomized trial.
So you're supportive. Anybody want to take the other opinion?
You know, I can guarantee you, once this randomized trial is out, then we have the cherry picking and say, well, you know, is this a biased, first of all, selection bias? Which valve are you using? Can we really say this is you know, the result of TAVR, or is this a result of a balloon expander versus self-expanding? I have my questions, even though I know the randomization sometimes resolves things. But as we see now with SMART, it's not resolving everything. The questions actually remain open, and we would see what's up to in 5 years.
No, but I think that it will be, by default, it will be selection bias, because all these studies that are being designed now, they use a screening committee to make sure that the bicuspid phenotype is accessible for a TAVI procedure. So that introduces already an important selection. I think an interesting aspect, if we are designing these trials, is what do we want? Do we want to compare one particular valve platform with surgery, or do we want to compare the best possible valve platform for an individual patient to surgery? And, you know, I'm also involved with the development of a trial, and I would prefer the latter.
Well, I think the Dedicate trial that was just presented and published a couple of weeks ago from Germany, which allowed valve selection, had, you know, probably the strongest benefit compared to surgery of any of the trials, better than the Evolut low risk, better than the Partner 3 at 1 year. Obviously, that's just 1 year, but it does suggest that letting the operator pick which platform may even be better. But I think the Eberhard's point is a very important one, is that whatever trial is done in the bicuspid space, I know the one that I'm involved in, you know, we've made a very intentional plan to collect a lot of data on the patients who are rejected. Because again, I think it's super important to understand how, you know, what proportion of bicuspid valves the study applies to, because again, there will absolutely be selection, and there should be selection. We shouldn't, you know, it would be criminal to, to put the valves in patients who are very poor candidates.
It's going to be like the Syntax trial, right? There was also a nested registry within that trial of the patients who were not eligible for randomization. I think the trials that I'm aware of in bicuspid or considering bicuspid versus TAVR also include registries, TAVR and surgery registries of patients who are not enrolled in the trial.
Yeah, so we wrote a paper on that a couple of years ago, and that was exactly the motivation. Was the Syntax trial, I think, got it right and helped us understand, both the benefits within the selected group in the middle, and and how big the groups were on the two edges.
So, Nicholas, what is your preferred valve in bicuspid and why? Do you have a preference for bicuspid valve?
Me?
Yeah.
For you mean the phenotype or you mean the platform?
Which platform? I think he said.
No, I don't have a preference. I don't have a preference. So this really is patient tailored. It depends on the phenotype. So a lot of the bicuspids have horizontal aortas, and then I'm already a little bit cautious with the self-expanding systems. On the other hand, if there is also LVOT calcium, then I would be more restrictive with the balloon expandable. So there's just not one answer to that question.
Let me pick on you, Nicholas, a little bit. Just a completely different subject now. We are going to be seeing over the coming years, including your study, several trials of TAVR for moderate aortic stenosis. And I want to ask you and then ask the panel to comment on what result would you need to see to make you say we should treat these patients with moderate AS rather than wait until it progresses to severe. So let me have the PI speak first, and then if there's other people who have
Well, I think you need hard clinical endpoints. That is what I'm believing. So obviously all these trials are using a hierarchical endpoint, and even TAVR unload, there is also, so you start with mortality, then with stroke, then rehospitalization, and then KCCQ. You hope that you don't need the KCCQ to make the difference.
Do you think the hospitalization endpoint should be convincing?
Well, I think it's a very relevant one.
I mean, it is. It's one hospitalization, though. Presumably, if somebody gets hospitalized for heart failure, they're very likely to end up crossing over and getting a TAVR. So have we really, helped them in the long term, or have we just kind of prevented, delayed their need for a TAVR a little bit, which may be a good thing?
It's an interesting concept, because if you get the valve earlier, you might also think, okay, but then you are at risk for degeneration also sooner. So it is an interesting discussion.
It's not guaranteed, to be always the right solution. That's what worries me a little.
But at the same time, as trialists, you also have to be realistic, and you have to compose a primary endpoint that allows you to end up with a realistic sample size, right? Obviously, you would design all the trials should be mortality trials, but go figure the sample size if you would only look at mortality in moderate aortic stenosis.
Yeah, I think it would obviously be much more convincing if, in the long run, there is either symptomatic benefit after everybody gets their AVR. The patients are somehow damaged by waiting. That's because that is the claim based on the observational data is we're going to save lives. Because people are dying from moderate aortic stenosis. We don't know. We'll find out.
And probably these pooled analyses that we keep on doing of randomized controlled studies make sense, right? To come up with a more yeah.
Okay, I think we need to move on to the second half. I could ask questions all day, but then everybody will get bored. So next we have Didier Cheche coming up to speak on imaging for standard TAVI, in particular on commissural alignment and coronary access.
Okay, good morning, everyone. So let's spend 7 or 8 minutes discussing about commissural alignment and coronary access after TAVI. These are my disclosure. What is the issue of coronary access after TAVI? We know that it may be quite a challenge, particularly for some platforms as the self-expanding supraannular ones, but we have accumulated knowledge altogether. When we exchange our experiences, we understood that there are tips and tricks to get a proper coronary access after TAVI. So I'm not going to go through all these elements, but definitely we have accumulated enough knowledge to do so. It's not so frequent to require the need for a coronary access for post-TAVI, but you need to acquire the skill set necessary to make sure that you can safely and efficiently cannulate the coronary arteries. There are some factors that are going to impact your ability to cannulate the coronary arteries after a transcatheter aortic valve implantation. There are some anatomical factors inherent to the patients, and you all know them. The coronary takeoff, the height of the coronary takeoffs, the bulk of the leaflets, the width of the sinus of Valsalva, the height of and the diameter of the sinotubular junctions. And these are the anatomical factors that have to be combined with some factors inherent to the transcatheter heart valve, the depth of implant, the location of the leaflets, whether it be intraannular or supraannular, and the commissural posts. Where is the commissural post located in regards to the ostium of the coronary arteries? So all these factors are combined, and these may sometimes make our life very difficult to cannulate the coronary arteries. From these factors inherent to the valve, maybe coronary commissural alignment is the most important, and you've heard that, and we keep on discussing this point meeting after meeting, but it plays a role and it has to be integrated into our contemporary practice. We cannot anymore just deploy the devices and expect that the hazard is going to do the job for ourselves. So if we are using self-expanding platforms, particularly the supraannular ones, the risk of coronary commissural misalignment may be more important. So what is the definition of commissural alignment? It has been proposed, you have several definitions, but the one that has been proposed by the Align TAVR consortium may be the most frequently utilized. And it's about understanding what is the off-axis location of the commissural of the self-expanding platform or the TAVI platform in regards to the commissure that you target. 0 to 15, it's a proper commissural alignment. 15 to 30, moderate, mild. 30 to 45, moderate, and more than 45, you have a severe commissural misalignment. So commissural alignment has potential benefits, promoting coronary access after TAVI, particularly in taller THV devices. We've seen that. Reducing the risk of coronary obstruction when you go for a TAV in SAV procedure. Dave has alluded to this point before. And this is also going to have an impact on promoting redo and efficient redo procedure, TAV in TAV, by decreasing the risk of sinus sequestration and coronary obstruction. Leaflet modification techniques are only going to be useful if you had a proper commissural alignment at baseline. And potentially, we've discussed these points more about the ellipticity, the pinwheeling of the leaflets, but as well as these factors, if you have a commissural misalignment, this may impact the frequency of halt and degeneration, gradient and degeneration of the THV. So for redo, you know that based on the height of the self-expanding platform, you may get access to the coronary arteries through the cells, on top of the cells, or beside the cells. So the better you are at achieving a proper commissural alignment at baseline, the higher that efficiency to cannulate is going to be for the redo procedure. So there is a new technique, that is that basilica-assisted technique, balloon-assisted basilica, that aims at increasing the opening that is generated within the leaflets. Before slicing the leaflet, you just expand the hole with a balloon, but this is only efficient, can be done if you have a adequate commissural alignment at the index procedure. So once again, you understand that it's very crucial to be efficient. So that commissural alignment is only proposed in combination with that cusp overlap technique, your cusp overlap projection. You need to identify that. You superimpose the coronary leaflets on the right part of the screen and the non-coronary leaflet on the other side, on the left part. Most of the time, it's an areocaudal projection, and the CT scan is going to provide you with that projection to make sure that you nicely locate the commissural post of the THV in front of the commissure, separating both coronary leaflets. So it tells us that the cusp overlap projection is the projection to use in contemporary practice. It's even getting popularity for balloon expandable platforms. Once we have that, we need to understand the markers, the landmarks that we have on the THVs, particularly important for self-expanding platforms. For the CTAP, for the Evolute platform, if you are using the Accurate Neo or the Navitor platform, you are more focusing on one of the posts, the commissural post that you will try to put exactly in front of the commissural, separating the left and the right leaflets. So to achieve a proper commissural alignment with the Evolute platform, we most of the time put the flush port at 3 o'clock, and this is going to maximize our likelihood of getting a proper commissural alignment. It's even easier with the Evolute FX platform. If you are using the Accurate Neo, most of the time you start with the flush port at 6 o'clock. And I have to say that this is the device that is extremely easy to get a proper commissural alignment because you nicely see the posts and you can nicely locate them where you want. It's a little bit more challenging for the Navitor platform. What I do is to start at 6, rotate the flush port 90 degrees, and then you do some push-pull maneuvers in the thoracic descending aorta to try to get a proper commissural alignment. For the balloon expandable platform, SAPIEN 3 doesn't work. Everything has been tried in terms of crimping the device. It doesn't work. Potentially with the X4, we're going to see a greater likelihood of commissural alignment, but this is this needs documentation. So, do we need coronary or commissural alignment? The answer is very simple. Commissural alignment works better. You have a lower risk of commissural misalignment when you use the commissural alignment technique. So there is no need to go for a coronary alignment for the vast majority of the patients. So the essentials to remember for this talk, so commissural alignment has to be achieved in contemporary TAVI practice, and we cannot do any more procedure without paying attention to that point. Commissural alignment impacts coronary access as well as lifetime management of the patients after the procedure, and it's really useful to understand the technique for self-expanding platforms, and I've described these techniques before. Thank you.
Thank you very much, Didier. We move on to the next talk with Nicolas, optimal planning of revalving for failing TAVR.
Thank you, Eberhard. So my talk is going to complement Didier's talk, David's talk, and also the talk by Carl Poon yesterday. So I will discuss also lifetime management, obviously, because if we are talking planning of revalving procedures, we are talking about lifetime management, and then we start discussing whether we need to start with a SAVR or with a TAVI and then follow up with a TAVI or a SAVR, or are we just thinking TAVI, TAVI, and again TAVI. If a TAVR valve fails, then obviously the standard or the treatment of choice should be a revalving procedure, so a re-TAVI. And this is why explant surgery is a high-risk procedure. So you see that the procedural mortality, 30-day mortality, 1-year mortality are systematically higher after surgery than after TAVI, and the events occur within the first month. After the first month, basically, both procedures, either a revalving procedure or an explant surgery, have similar outcome, at least in the short term. So what are the estimations, the market estimations for these revalving procedures? And this is quite interesting. This is a slide that I borrowed from Philippe Généreux, where he looked at the valve-in-valve procedures. So valve-in-valve, either a failing surgical or a failing transcatheter valve. And in green, are the valve in surgical valves, so TAV and SAF. And in the last decade, we predominantly were doing that. But in the year 2021, it started with revalving for failing transcatheter valves. And it's expected that by 2027, the TAV in TAV will surpass TAV in SAF. And then it will completely escalate a little bit, if you will. And by 2035, you will have a 6 times increase in the number of revalving procedures. Obviously, that is because the market of TAVI is exploding. But this is an important perspective, and that is why prospective trials become very relevant. And we are entering the era of prospective studies. So far, we only have anecdotal case presentations, but now there are two prospective studies, the Re-TAVI and the Revalve study, that are ongoing or about to start in Europe, looking into the use of sapien valves for revalving or any commercially available valve for revalving. Both trials are industry sponsored, and there will be core labs for echo and CT scans. So what are the revalving essentials? I'm not going to dwell on commissural alignment. Didier already nicely demonstrated how to do that and why it is important. We also learned from Dave's talk and from the presentation by Carl yesterday that there are several important principles. So the valve to coronary distance, the valve to sinotubular junction distance, also the implant, not only of the second transcatheter valve, but also of the first transcatheter valve is very relevant. And then there is this concept of neo-skirt that basically follows by default the implantation, the revalving procedure. Leaflet overhang is maybe a little bit overemphasized lately. I don't think that leaflet overhang has important consequences, at least in the short run. And then we will briefly focus on transcatheter frame expansion and the residual valve area. And that is, I think, an important concept if we think valve in valve in valve in the future. So there will be 3 layers of skirt if you do a revalving procedure, and just assume the aortic wall. So if you implant your first valve, you have your sealing fabric, if you will. Then you have the cobalt chromium or nitinol alloy. And then you have your leaflets, either porcine or bovine. Well, if you revalve that, you introduce another sealing fabric, another either nitinol or cobalt chromium, and then there is the valve leaflet, but you also have to bear in mind that there is also the native leaflet. So you can imagine that by adding and stacking up these devices, you will affect your residual valve area. We are also now starting to use simulations, computer or CT-derived simulations, to basically predict how the valve will look like and also help us with determining the optimal implantation depth. And this is an example that was published by Dargan, where he did the simulation for a failing evolute valve, and then looking at the 4th node, the 5th node, or the 6th node, it will have consequences in terms of leaflet overhang, but also the neo-skirt. Obviously, if you implant higher, the neo-skirt will also become higher and might be more and more affecting coronary access. In this particular example, the sweet spot was the node 5, but then again, it's also not so easy to then execute as such, as we also saw in the live case yesterday. So how does this simulation look like? Well, basically you upload your CT to, for instance, FEOPS, and then they will make these nice animations where you get a visual appreciation of how the valve, a revalving procedure, will end up looking, and how the coronaries, for instance, will be preserved or will be affected by the revalving case. So lifetime simulation. So I told you about this valve area that will be affected by stacking up devices. And just assume this is a case that we did. So the patient started with an area of 440 millimeters square and received a 29 millimeter evolute. Well, the dimensions after the index TAVR we did another CT, a follow-up CT. Well, the area was dropped by 5%. And became 420 millimeters of mercury. That valve also degenerated and required a revalving procedure. So we continued with revalving with an S323 based on the residual valve area 422. Now, after that sapien in evolute implantation, we did another CT scanning. Turns out that the area has dropped now to 334 millimeters square. So we have an additional drop of 20%. Well, if you now make the assumption that you need another valve, if also that valve would degenerate, well, then I think you might want to select another sapien valve. Well, your area is gonna drop to 300 millimeters square, so another drop of 10%. Overall, your valve area is dropping by 30%, and so you'll end up in a zone of prosthesis-patient mismatch. I think this is an important concept when we are talking about lifetime management. Well, you do have to consider also a surgery at one point in time of those patients. So in conclusion, TAVI has surpassed surgery as the preferred therapy for severe aortic stenosis. We know that the frequency of transcatheter valve failure will increase. Revalving is the therapy of choice for transcatheter valve failure, and CT modeling and simulation may complement revalving planning. Thank you for your attention.
Go ahead.
Thank you very much, Nicolas. A very important presentation. Next, we will move on to Dr. Faisal Youssef Almajid, presenting the Asan Medical Center's CT algorithm for pre-TAVR evaluation.
Thank you, Dr. Cohen. So I'm Faisal Almajid. I'm an international fellow at Asan Medical Center, and I'll be discussing our pre-TAVR evaluation CT algorithm. To start off, I have no disclosures. ECG-gated multi-slice CT plays an essential role in the assessment of coronary artery disease, as well as the anatomy of the aortic valve, the aorta, and the iliofemoral arteries. This helps us in identifying the proper access site and the proper valve platform that should be used. This, of course, provides quality assurance because CT is consistently reliable, providing measurements that are backed by strong inter-reader and inter-reader correlation. The CT planning process involves usually 1 to 2 structural fellows and the device representative who each perform separate measurements. These measurements are then discussed together in real time to reach a consensus, and the collective findings are presented in an MDT to finalize the TAVR strategy. A typical TAVR procedure at AMC involves usually no transesophageal echo. 98% of our cases are done without general anesthesia, and it's a 30-minute procedure with 1-day stay in the CCU followed by discharge, and the patient is then streamlined to cardiac rehabilitation. This is a typical PowerPoint presentation that is done throughout each and every TAVR procedure at our center. And one should keep in mind when doing the measurements the concept of annular dynamism. The annulus size changes throughout the cardiac cycle. So we have to measure ideally at the end systolic phase, where we usually find the largest annulus at 20 to 30%. However, in the presence of septal hypertrophy, then we should also measure the diastolic phases. AMC is a predominantly balloon expandable valve center where 93% of our patients get exposed to balloon expandable valves, mainly the SAPIEN 3 and the SAPIEN 3 Ultra. Sizing matters because if you undersize the valve too much, you may end up with paravalvular leak or embolization of the valve. However, in case you go on the other spectrum and oversize too much, the patient may end up requiring a permanent pacemaker or end up with annular rupture. So that's why we have to aim for that sweet spot in the middle. The AMC TAVR registry correlated area oversizing with the requirement for permanent pacemaker. It also correlated the amount of annular calcium with more than moderate PVL development. For the S3 valve, we reached a consensus where that 15% oversize is the optimal cutoff or the maximum cutoff. For pre-dilation, 400 millimeter cubed of leaflet calcium is our cutoff for attempting pre-dilation for a patient. Now, the S3 and the S3 Ultra differ in that the ceiling outer skirt of the S3 Ultra is 40% longer, which causes less paravalvular leak, so we aim for a smaller cutoff for area oversizing. For patients with low calcification, we go with 5 to 10% oversizing. Patients with heavy calcification, 0 to 5. Again, the same for patients with bicuspid aortic stenosis and low calcification. And finally, patients with bicuspid AS and heavy calcification, we would go ideally for 0% oversizing, and we could go down to as low as minus 5% undersizing. The risk of coronary obstruction substantially increases when there is low coronary height, as we all know, less than 10 millimeters, and when the sinuses are shallow or narrow with less than 30 millimeter in diameter. This put together, along with the accumulative experience of our operators and the development of valve platforms, had led to a decrease in our mortality over the past 10 years from 4% to 0.4% last year. Our first case is a patient with an annulus area of 434. He has a short membranous septum and a calcium score of 146. So we have a patient with low calcification. Our ideal goal is 5 to 10% oversize, and then overfill according to the presence of PVL. So a 26 millimeter valve would do the trick here. We aim for minus 2 cc underfill at 9.2% oversize. The valve was implanted, and there was minimal PVL. The patient, however, did require temporary pacemaker for 24 hours because he had a short membranous septum. The permanent pacemaker incidence in our center has been ranging from 5 to 7% over the last 5 years, and this is in keeping with global standards. Our second patient is a patient with bicuspid aortic valve, Sievers type 1, with a calcium chunk around the NCC and an annulus area of 466. The total calcium score is 828, so we have a patient with bicuspid aortic stenosis and heavy calcification. So our aim is minus 5% area undersize up to 0%, and then we overfill according to PVL. A 26 millimeter valve was deemed sufficient here, so we had to go with minus 2 cc underfill at 1.8% oversize. The valve was implanted, and there was, I would say, mild PVL. So we aim to post-dilate with increasing 1 cc to reach minus 1 cc underfill at 6.6 area oversize. The patient still had some PVL, however, unfortunately, but he could live with that. So our AMC TAVR registry showed that post-dilation substantially reduces the amount of moderate to severe paravalvular leak without an increase in the need for a new permanent pacemaker at 1 month follow-up. Our third case is a patient with an annulus area of 598, quite sizable, sinuses and STJ, with a total calcium score, severely calcified, 1,588. So we aim for 0 to 5% oversize. We went with a 29 millimeter valve, so we had to use the SAPIEN 3 rather than the SAPIEN Ultra. So our aim here is 5% to 10% area oversize. We went with 5% at minus 1 cc underfill at 5.2% area oversize. We started off pre-dilating due to the heavy calcification. There was some mild PVL, but we deemed the results to be adequate. So in conclusion, CT TAVR planning and MDT collaboration ensure precise valve selection and improve patient outcomes. This can be crucial for navigating complex cases. In the era of low surgical risk TAVR, comprehensive CT analysis is critical for optimal valve and patient selection, ensuring enhanced procedural outcomes. Finally, employing a CT sizing algorithm with a possibility of provisional post-dilation to achieve the intended oversizing ratio has proven to be both safe and effective. Thank you.
Thank you very much for a very clear presentation. So our final presenter, before we get to our second panel discussion, back for a reprise, is Dr. Jung-Min Ahn. Who's going to be speaking about the history of TAVR at Asan Medical Center.
Thank you. I just summarized our center's the clinical data. So globally, Alan Glibia started TAVR, invented TAVR, with the surprise. Then our center's TAVR program started in 2010 with also surprise, big surprise. TAVR successful, but some iliac artery dissection. So patient go to operation room, but still patient survived. TAVR volume in Asan Medical Center up to now, the 1,887 cases. This year a little bit small, but I'm expecting that they catch up soon. So predominantly we implanted the Sapien system, but Eberhard, the self-expandable device, frequently saved the patient's life. I selected the self-expandable for the very high-risk patient, poor peripheral access. This patient, Sapien system cannot passing through the peripheral, so I changed the system to the Evolute and finally successful. And sometimes we only have one chance. So I would and stable hemodynamic. So I would like to implant the self-extendable device. This patient is a 64-year-old. Ejection fraction is very low. So the one shot, one kill. The patient survived and successful. So patient age is 80, not a change much. And TAVR for bicuspid aortic valve overall so far is 10%. Annually increased number of bicuspid AS TAVR patient. At this SS score, initially we started a very low risk, but nowadays the STS score is intermediate. So high risk population is increasing nowadays. So valve in valve, after we have 15 years history, so nowadays we had a valve failure patient. Valve in valve, particularly TAVR in TAVR is 33, TAVR in TAVR is 16, and bailout TAVR in TAVR is 18. So what is the difference in other medical centers? First, I think the perfect heart team collaboration and minimalist approach and ANC CT algorithm. Every week in the morning, Friday, we met the surgeon and echocardiographic specialist. This is the echo specialist, 2 surgeons, and eating some breakfast. And Doyun present the patient. So I persuade my surgeon, this is good for TAVR. So this is our weekly event, Friday weekly event. But nowadays, many smart cardiac surgeons send the patient to the cardiologist for TAVR because they had a long list of patients to have 2 operations. So what is the minimalist approach? The no general anesthesia, no TE, the very short time, 1 day CCU, discharge, 3 days. Sometimes the other countries, the 1 day discharge, but in Korea, the hospitalization cost is very cheap. Hospitalization cost is just $10 or $20 per day, even in the CCU. So we don't need to discharge the patient quickly. And cardiac rehabilitation system. So from the 2015, the rapid increase in the monitored anesthesia care, thanks to my anesthesiologist specialist. Sometimes nowadays, we will learn how to sedate the patient, my fellows, my nursing staffs. So nowadays, sometimes we've done the TAVR case in the cath lab without the help from the anesthesiologist. We have a dedicated person, Dr. So thank you. So CT analysis, we quantify the calcium. I think this is very important. Angiographic calcification is incorrect. So bicuspid aortic, tricuspid aortic valve, we quantified. Science have to quantify anything. So quantify the calcium, and we consider location and adjust the sizing according to the quantification. So far we have I summarized the 1,600 patient, age is 80, STS is 4, diabetes is 36. Procedure success is very high. Conversion to surgery is 1%. Coronary obstruction per patient. A new pacemaker is 8.7. Significant p-value 2.5. So length of hospitalization is 1 week. This is 30-day outcome overall. 30-day death is 1.4. Stroke is 3.1. But the disabling stroke is very rare. Bleeding is 3.2. 1 year outcome is death. 1 year 7.2. Disabling stroke is 0.9. This is mortality according to the age years. Last year around 2%, but this year no mortality case. Disabling stroke, nothing now recently. The vascular complication, nothing recently. Permanent pacemaker implantation rate is nowadays recently around 7%. So according to the device, previous covalent high pacemaker implantation rate, but the new version of covalent Evolve Pro is 12, Sapien 30, Sapien Ultra is 7%. Segmented PVL nowadays is very rare. This is overall outcomes 2023 AMC. All-cause mortality is 1.3. Disabling stroke is very rare. Vascular complication is 4.2. Pacemaker implantation rate is 7. Significant PVL is 0.4. So 8 years ago, Alain Grube said that he expected the future of TAVR. So TAVI is indicated in the patient who are not optimal candidate to surgery in 2016. But he said that 2020, SAVO is indicated in patients who are not optimal candidate to TAVR. His dream come true in every AMC and everywhere, I think. Thank you.
Thank you very much. We're right on time, so we have another 15 minutes or so for discussion. Kentaro?
Can I ask a question? So I have one question to Nicholas. Thank you very much for your fantastic presentation. And nowadays, we have more and more cases of TAV and TAV procedure. I think it's quite important to predict the coronary occlusion after procedure. And what do you think is the best criteria to predict coronary occlusion? So I'm not quite sure that if VTC distance is quite predictive to predict the coronary occlusion. Do you have any thoughts on that?
Well, there is not one answer to that, right? So I think a VTC less than 3, so the cutoff is either 3 or 4, depends on the literature. But if it's below 3, I mean, it becomes a challenge to enter the coronary. And but that doesn't mean that there is a coronary obstruction. It means that it becomes very difficult to re-enter the coronaries down the stretch of the patient, you know, when he needs, for whatever reason, a coronary angiogram. I think the major reason for, or risk factor for coronary obstruction, that's a tough one. I don't know. I don't know.
Thanks, David. Great talks. Don't want to put you on the spot, Didier, but I have to. After TAV and TAV, do you have any tips about coronary access leading to that point? I mean, coronary obstruction not happening doesn't mean coronary access in the future. And the second point to you, Nicola, in terms of the FEOPS and AI, we now know that leaflet degeneration in TAV may be different between self-expanding and balloon expandable. All the CT predictions based on pristine CTs, right? Pristine leaflets. How do they account for it from FEOPS and other people? Maybe Didier first, if you have any tips.
Yeah, that's a very interesting point. I don't think that we have gathered enough experience yet to properly answer your question. But I think that if the main issue is if we have to get access to the coronary arteries through the struts, and then it's become an issue if we have that neoskirt that prevents us from connecting with the ostium of the coronary arteries. This, I think, we need to develop in the future and envisage devices, leaflet modification devices like the shortcut. You're going to see the result of the IDE at EuroPCR, but to make it short, once you open the leaflets, you can get access easily in 100% of the cases to the coronary arteries. So I think it's going to be potentially the first step for when we will need to get across the struts of the new stent frame.
Yeah, I agree with that, Didier. I think we will rely more and more on ancillary techniques to be able to enter the coronaries. Then in terms of the simulations, we are still relatively early in the process. So FEOPS is developing its software. It is AI induced, but there still needs more machine learning to be done. What they don't take into consideration at this point in time is device-host interactions. And that is, I think, they do interpret device-host interactions with their initial software program for native anatomies, but they haven't introduced that for the revalving procedures. And I think, at this point in time, the simulations gives us a visual, a very nice visual, but it also gives us a warning signal about other aspects. So not necessarily the very accurate real-time situation that you will get because of degenerated leaflets and so on that are not taken into account. But they do give you a very good appreciation of your valve area or your residual valve area. Yeah.
Michael, here. Oh.
No, go ahead, Michael.
Didier, can I address you? You have shown us the importance of commissural alignment. There are many maneuvers with different valves try to align the commissure, but how often or how accurate do we need commissural alignment? Because if it's not aligned, you need to pull the device to the descending aorta, rotate, put it back again, and then you find it's still misaligned, and then you have to pull back. So how much should we do to try to get a perfect alignment? And does it depend on the clinical condition of the patient, age of the patient, and so on?
Yeah, that's a very contemporary concern once again. I guess it first depends on the condition of the patient. If you are dealing with a younger patient or a patient at higher risk of coronary disease in the future, we need to be extremely efficient in achieving commissural alignment. There is a margin of tolerance. If you do you misalign between 0 and 30 degrees, it's acceptable. So I think it depends also on your experience with the device that you are using. Some are easier than the other ones. And I know that Philippe has a lot of experience with the Accurate. And Accurate Neo 2 is quite efficient in making sure that you nicely correct the things. But I would strongly recommend to do it for every single procedure. We cannot afford anymore. We are talking about TAV in TAV, redo procedure. So let's be extremely efficient at the index procedure.
Didier, I have a simple question. Evolute Apex has 3 visible dots in distal end. So can we check the coronary alignment using that 3 visible dots?
Yeah, the FX has the ability of improving our visual impression of the accuracy of the commissural alignment. The dot is not exactly located below the commissural post. It's slightly offset, but it's a nice tool. But most of the time, I'm not sure that it's going to be extremely accurate, but from the first experience in the US, 96% of the patients had the proper commissural alignment on CT scan evaluation. So it's an add-on.
Can I just ask one quick follow-up, then we go to Eberhard? So how, we clearly, commissural alignment is essential for self-expanding valves. How important do you think it is for the shorter frame devices? Is it equally important in your mind?
I think that in the future it's going to become equally important because we will deal with TAV in TAV. So we are aiming at high implants, higher and higher, to make sure that we get a proper hemodynamics, no regurgitation. So we will need to put into the equation the commissural alignment for short stent frame devices as well. Otherwise, we're going to end up from time to time with patients with coronary obstruction or no option for cannulation.
Yeah, I totally agree. It's because if we don't align the commissures, we can't do leaflet splitting. It's not going to help. So I think it's very critical to plan.
Yeah, for a second, would like to play the devil's advocate here. And we have been criticizing the surgeons that they don't do the root enlargement, that they implant the small valves. And if I may say, now when these valves degenerate, that cardiologist has to kind of overcome these problems. Why don't they do this? Why don't they do that? If you look at the curve of Philippe, with this steep rise of TAV and TAV, are we not running into the same problem that now it's easier, obviously, to implant a TAVR valve? We are at the beginning of trying to understand, to optimize valve-in-valve situations, and now we have an increase, projected increase, 6 times, and we don't even know how we're going to deal with that. Don't we have to face the same criticism at some point and saying, well, why don't you at the first procedure, because the first cut is the deepest, why didn't you ask the surgeon to put in the best possible valve and then follow up? I've been, you know, Nicolas's layer animation gives you the problem. I'm not talking about an 80-year-old. I'm talking about the tendency of moving down by age. And then we have a 65-year-old. That's easy to put a TAVR valve in. Not much can be said, you know, this valve or that valve. And then we might have two TAV and TAVs. And, you know, should we not consider the first a little bit more careful and selecting which procedure would be the first one, instead of just putting the low-hanging fruit and put a TAVR valve in?
I mean, I think it's a great question. Nicholas, you want to weigh in?
Isn't that the shared decision-making that we need to do? I mean, we as a physician need to inform our patient and need to predict this is what can happen over time, and then, you know, that it's an individual decision. And I think the opinion of the patient also plays a part. I think I can understand if a 65-year-old will say, "Listen, give me a TAVI because tomorrow I want to resume my working activities." That's also an argument, and okay, it might have some consequences down the stretch. But you know, as we are getting better and better, and again, we are still very early in this game of revalving failing transcatheter valves, but we will get better, and we have already tools and techniques to do the commissural alignment. These simulations will get better and better. So I'm not so skeptical. But again, I agree with you. The first cut is the deepest, and it is not a bad option to have a surgery first. Yeah.
Didier, do you want to comment on that at all?
Yeah, here on the left.
Oh, I'm sorry.
I have.
Didier, go Didier, because I called him in there.
No, you first.
I have a question for Professor Ahn.
I agree.
Can we? Okay, you agree. Go ahead. Thank you.
Professor Ahn, thank you for a nice presentation. In Asan Medical Center, usually choose the balloon expandable valve, but from the SMART trial, patients with the small annulus, the self-expanding valve shows the better valve performance. How about the patient with the small annulus in Asan Medical Center?
Yeah, thank you. Very, very important questions. After the SMART trial, I considered the self-expandable device in the small annulus. But even though the if the self-expand device solved some problem, because particularly the coronary access problem, then I will consider more the self-expandable device in the future.
Let me add to that, and I think David already made a very important reference to the DEDICATE trial. I think it is patient-tailored platform selection. I mean, yes, SMART gives us an important message in terms of bioprosthetic valve dysfunction, whatever that means. But at the end of the day, there was no difference in clinical events. So that is one. We will see what happens at 5 years. If there is no crossing separation of the curves, then this bioprosthetic valve dysfunction endpoint doesn't mean anything. So we'll have to see. But I think that if a patient has a horizontal aorta, you might prefer, even in a small anatomy, a balloon expandable valve. And if there is excessive calcium, you might want to prefer a self-expanding. So it's okay.
Yeah, I mean, again, we don't know that that's what drove the DEDICATE results. Maybe we're just getting so much better at TAVR, but it's certainly, you know, it's the one big difference between the DEDICATE trial and the two company-sponsored trials here in the United States, where the valve choice was restricted. And so it's hard to ignore that. I think, you know, as was mentioned, the SMART trial has been very illuminating, and I think the 3 and the 5-year follow-up will be very telling, because again, if it shows major differences in outcomes or even quality of life or rehospitalizations, that's going to be a very, very important consideration, at least for the Western patients. Maybe it will be different in Asia, because again, Asian patients who have small annuli are very small patients too. And so we hear that from Japan, that, you know, the vast majority of their patients have, would already, qualify for the SMART trial, and, yet they have excellent outcomes with balloon expandable valves. Your thoughts again there, Jung-Min?
But Korean is not that small. So Dr. Hayashida may have some comment because Japanese is smaller than Korean. So
Yeah, that's true.
All right, well,
Yeah,
let the Japanese comment.
Actually, the Japanese patient much smaller than Korean patients, and nowadays we have the SAPIEN 3 Ultra Resilier, which provides much better hemodynamic performance than the SAPIEN 3. And we conducted the initial study comparing the SAPIEN 3 Ultra Resilier and Evolute or Navigator. We don't see that much significant difference in terms of the invasive measurement. So we see some difference by echo, but we didn't see any significant difference in terms of the invasive measurements. So we need to take into account discordance as well.
Yeah, I mean, that's a persistent issue, and I think, again, that's why we need the clinical follow-up to try to help us sort out whether this is just an echo finding or whether it is a very important finding for what happens to the heart.
In addition, we have to clarify the pronounced importance of patient prosthesis mismatch. Many data show that, particularly the surgical AVL data show that PPM is associated with longer mortality, but many TAVR data is not. So we need to define the importance of PPM in the future. Thank you.
All right, I think we are just out of time, and I really want to thank the presenters who were fantastic and stayed on time, and the panel for an outstanding discussion, and I hope you all have a wonderful rest of the day. Wonderful.